Okay, so our first discussant, first of all, I'd like to say hello to everybody for my co-moderator, Laurent. And our first lecturer is Mark Peterson from New York City. Prior to that, he was from Toronto. What should guidelines for aortic valve regurgitation look like in 10 years? Dr. Peterson.
All right, thank you, Laurent. Thank you, Joe. I have to hit the thing here, eh? Okay.
Turn him on.
Which one's this one? Okay, well, thank you for the invitation. This is the advancing here? Thank you. Okay. Yep. All right, thank you for the invitation to speak. I was asked to talk about the misunderstood valve lesion, as Joe likes to call it. What happens looking at the guidelines, where the guidelines have been, understanding what's informed the last few versions of the guideline, and where are we going? What should they look like in 10 years as it relates to the treatment of aortic regurgitation? These are my disclosures. I think most of us know the natural history of aortic regurgitation. This is a seminal paper written in Circulation in 1999, which demonstrates the association between symptoms and outcome. The more advanced the symptoms, the worse the outcome. It also demonstrates clearly that patients with large ventricles, particularly end systolic dimension, do very poorly over time. A few other facts about chronic aortic regurgitation: the rate of progression of symptoms and or LV dysfunction is relatively slow, less than 6% per year. The rate of progression to asymptomatic LV dysfunction is less than 3.5% per year, and the rate of sudden death is relatively uncommon. But once LV dysfunction has set in, the rate of progression to symptoms is 25% per year, with a mortality rate of 10% per year. And this process is more rapid in elderly patients. What's important from that study that I just showed is the association between even what we call relatively normal levels of LV function, so the patients with EFs of 50 to 55%, they have an excess 10-year mortality of 35%. And again, once the LV functions less than 50%, the long-term prognosis is horrendous. Well, what's the impact of aortic valve replacement on outcome? So once LV dysfunction is set in, these are the worst line, or the dotted line is the EF of less than 35%. There's a penalty, a mortality penalty, both immediately following surgery, as one would expect, but there's also a very severe long-term penalty. So once the LV function's poor, the long-term prognosis is horrendous, and you can see a dose response through to EFs of 45 or 50% and above. And the same is true for symptoms. If you are operated on with poor LV function, the likelihood of heart failure symptoms is obviously going to be higher. So stated differently, survival increases and progression of heart failure decrease with earlier intervention. And this really informed the 2012 European and 2014 American guidelines, which basically said that class 1 symptoms were restricted to patients with heart failure symptoms and low ejection fractions. But we can see that the prognosis is already quite poor. So that data was from 10 years prior to these guidelines, and these guidelines are already out of date. The 2B guidelines really focused on the diameters, but these were not level 1 level of evidence, despite the signal that patients with large ventricles did poorly over time. So should we just sit back and watch asymptomatic aortic regurgitation? There's a lot of patients who don't have EFs less than 50%. They have low normal EF. We know that if they have severe aortic regurgitation and we repair or replace the valve, the LV function is going to drop. And many of these patients on 2D echocardiography didn't meet guideline criteria for surgery. So this is an important paper that asked the question, are guideline triggers associated with adverse outcomes? So one of our panelists here was an author on this paper, and they whittled down a number of patients to roughly 356 patients that underwent surgery with aortic regurgitation and stratified them according to whether they had class 1 triggers, so that is symptoms or LV dysfunction, or patients who were asymptomatic and had either class 2A, 2B, or had no discernible triggers for surgery according to the guidelines at the time. So again, we see that postoperative survival is related to preoperative symptoms. The higher class of NYHA, the worse one does over time. And most of these patients in this study actually had valve repair rather than replacement. But the same is true if this graph looks at the number of patients who started off with NYHA, class 1 symptoms, and rapidly progressed to NYHA 3 or 4. And in other words, waiting for symptoms, waiting for the appearance of symptoms, even though they had been in class 1, has a mortality penalty over the long term. Again, we see that they noted that preoperative ejection fraction above and below 50% had a mortality penalty, but even at 10 years, patients with EFs over 50% still had a signal to less than a lower mortality than the age and sex match population. And then looking at end systolic index, again, waiting for patients who had an indexed LV systolic area of over 25 millimeters per meter squared, which is a class 2 indication according to the set of guidelines that informed this study. There was a huge mortality penalty. So looking at it differently, looking at the hazard ratio according to various indexed left ventricular systolic dimensions, one can see that if you wait to the class 2 guideline, class 2A guideline, patients already have a hazard ratio of 2, and the hazard ratio really starts to increase around 20. So the guidelines at this point are already not reflecting when the mortality starts to increase. Another paper looked at the same question. Do guideline-based indications result in an outcome penalty for patients with severe aortic regurgitation? And again found that patients with a class 2 indication incurs a long-term survival penalty over the period of 10 years. And so finally, in that paper, looking at survival based on indication, patients with class 1 triggers, so again, symptoms, LV dysfunction, as would expect, had a severe penalty long-term associated with a 59% 10-year survival, whereas patients with class 2A or no triggers had much improved survival, again now approaching the age and sex match population. What was interesting is that over a broad range of LV function, you can see the hazard ratio even at 60% is above 1. There seems to be a slight inflection point around 53. But LV function was variably associated with an increased risk of death. Another study asked the question, is an EF of less than 60% predictive of death after AVR? And it appears to be. So even in the range of 50 to 59%, there's an increased penalty watching severe aortic regurgitation. Here's some additional recent data that informed the 2020 version of the guidelines. This study asked the question, these are patients that are asymptomatic with normal left ventricular function, and they looked at the difference in survival based on LV size. And so in this study, they found that early aortic valve replacement in asymptomatic patients with normal ejection fractions, normal heart function, and a dilated LV did worse than patients who, in other words, patients with large ventricles despite normal LV function did worse than patients who did not have enlarged LVs. And then this is just a number of studies looking at, the question of really where along the size continuum in terms of end systolic dimension should we be offering surgery. And remember, based on the 2014 version of the guidelines, there was only it was a class 2 indication to operate at above 25 millimeters per meter squared. But all three of these studies show that really the inflection point, the risk of death starts to rise at a number of 20 millimeters per meter squared. And this signal was consistent across all three studies. And looking at it differently, looking at survival over time, patients with end systolic dimensions less than 25 did better than those with end systolic dimensions over 25. So the new guidelines were improved, but not perfect. So again, the 2020 and the 2021 ACC and European guidelines demonstrated, once again, class 1 indication for symptomatic patients, asymptomatic patients with LV systolic dysfunction, so this was carried over from the previous set of guidelines. But what was new was patients who had, in the European set of guidelines, patients with enlarged systolic dimensions over 25 millimeters per meter squared, that now became a class 1 indication. The American guidelines kept this as a class 2A indication. The European guidelines acknowledged that potentially there was a signal over 20, as we just saw with the previous data, and moved that into a 2B indication. Whereas end diastolic dimension, I didn't show you the data, but previous studies had looked at the association of end diastolic dimension and found a relatively poor correlation with outcomes, so this was kept as a 2B indication. So is early surgery versus watchful waiting outside of the guidelines something that we should endorse? Well, this was a small paper that looked at 160 patients, again, asymptomatic severe AI, and they asked the question, is conservative management with cardiology follow-up equivalent to surgery? And it appears to be. And so this is over a period of observation. Again, it's a relatively small study, but in this study, aortic valve replacement, which was the primary modality for therapy, versus watchful waiting, had similar outcomes over 10 years. This is event-free survival. It was, again, statistically not significant. What I haven't shown you is the difference between the two additional groups, the watchful waiting group. So if the patients were followed very carefully in a cardiology clinic with regular echo follow-up, there appeared to be no mortality cost to watchful waiting in selected patients, whereas patients who were not followed, sort of real world, fared more poorly than those who were followed carefully. So the way these patients are followed obviously matters. As sort of stated here, similar survival in the two groups, better survival was observed in conservatively managed patients with regular follow-up. So we know that we can't just siphon off all asymptomatic patients without LV dysfunction for surgery. These are papers, we've seen various versions of the papers, particularly in Ross talks, that looks at the outcome of conventional aortic valve replacement in young patients. And we know that in young patients there's also a mortality cost with tissue or mechanical valve replacement, such that they report 15 year. This is a California database published in the New England Journal of Medicine a few years back. And there is a mortality cost by implanting a tissue or mechanical valve, particularly in young patients, such that conventional aortic valve replacement is viewed really as a palliative operation. And so the goal with the future set of guidelines should be to identify the earliest transition point from adaptive to maladaptive remodeling. It's aortic insufficiency and the changes in the ventricle are a slow process, versus operating too early and incurring the penalties and the potential complications from death and stroke from conventional aortic valve replacement. So how are we going to move forward? Well, I think what is recognized increasingly is that we need better improved quantification for LV size. We still often rely on end systolic and end diastolic dimensions, but we know from clinical practice that this is often largely very inaccurate, and we should be moving towards, we should be talking about volumes. Many of the guidelines are based on old data and two-dimensional data, but the extent of LV remodeling is better reflected by volumetric data. And so we can look at starting to incorporate measures from cardiac MRI, which is the gold standard for LV volume assessment, and by transthoracic echocardiography. The next speaker will be speaking about how to estimate volume from transthoracic echo, and the new versions of AI software are quite good and help make reproducible measurements of LV systolic and diastolic volume. And so the question is should the new guidelines incorporate LV volumes, measures of interstitial fibrosis, longitudinal strain, and other measures? And so here's a paper that looked at the outcome of patients with chronic asymptomatic severe aortic regurgitation by LV end systolic volume index, and it appears that over 40-45, the risk of death starts to rise. And this was demonstrated in another paper looking at CMR, and again, around 40 to 45 appears to be the transition point where you start incurring a penalty of worse outcomes over time. Cardiac MRI we can obtain reproducible measures of aortic insufficiency, and generally accepted that regurgitant fraction of over 33% denotes the transition from moderate to severe aortic regurgitation. And this paper looked at the outcome of patients with regurgitant fractions on MRI of over 33%, again asymptomatic, and patients who don't have surgery have a horrendous outcome over time with a regurgitant fraction over 33%. And similarly, patients with large volumes by end diastolic volume do very poorly over time. So I am short on time here, so I'll just wrap up by saying that there's research into looking at whether or not fibrosis is indicative or predictive of poor outcome, as well as longitudinal strain. And this paper on the right demonstrates that patients who have normal LV function and are asymptomatic but have markers of poor LV strain do more poorly versus normal strain patterns. I'm just going to skip along here. So what should the 2030 guidelines or the 2035 guidelines look like? Well, we should move the needle to an end systolic index of 20 millimeters of mercury, 20 millimeters per meter squared. We should start incorporating volume indices. Strain is predictive in patients with normal LV function. So in other words, abnormal strain patterns may trigger an indication for surgery sooner, and then using more CMR-based markers. I was going to just quickly cover repair, but I'm going to skip this and be provocative and say that in 2035, perhaps, especially in high volume centers that are expert at valve repair, perhaps the presence of severe aortic regurgitation alone and even small indices of increased LV size, provided the valve is repairable, just like in the mitral space, perhaps we should be operating on almost anybody with severe aortic regurgitation. All right, thank you very much.
Thank you very much. We keep the discussion for the end, and we invite you on the podium. So it's my pleasure to invite the next speaker, Geraldine Ong, who is going to talk us about echocardiographic assessment of aortic regurgitation to guide aortic valve repair. Please, Geraldine. Thank you.
You can bring up your coffee if you want.
Yeah. How do I get out of this? All right. Yeah, I got it. All right, good morning, everyone, and thank you for having me. All right, so we're going to talk about echo. So in the echo lab, our approach to aortic regurgitation is the following. So the first thing we want to do is define the mechanism of the disease. Are the cuts normal, abnormal? Are they prolapsing? Are they small, anatomically restricted? We want to define that. Then we want to grade the aortic regurgitation severity using both qualitative and quantitative assessments, parameters. And we want to provide you some other associated findings that may affect the timing and the eligibility of surgery. As we all know, the guidelines cutoff values are quite advanced in the disease process, so those early parameters with smaller dimension, notably, or other findings can inform us and perhaps move this in the future. So all these information can be obtained on a transthoracic echo. So a transthoracic echo, a standard study, includes 120 views. So like when looking at such a study like this one, just with the first view, this is a parasternal long view, immediately we can already have a lot of clues saying that this patient most likely has severe aortic regurgitation. You can see just by a glimpse that the LV is dilated, the LV muscle mass is increased by the thickness of it. I can see the ventricle so dilated, there's tenting of the mitral leaflet, so there's remodeling on that side. The aortic valve annulus is dilated, and I can already see some prolapse of the right coronary cusp with a very eccentric jet. So in our lab, we like to use biplanar views. So this is a view on the left side, this is a parasternal long, and we can simultaneously obtain a 90-degree views and having the short axis simultaneously. And then we can sweep through the valve from the LVOT to the aorta and pinpoint the leaflets themselves. So every machine nowadays, every vendors have this capacity. It's not something that's difficult to have. It comes with the package. The probes almost all have 3D capacity that can obtain these images. And what's useful for this, having this simultaneous view, is that we can sweep through the aortic valve and identify precisely which cusp we're looking at and see which one's faulty. So as you can see, then the non-coronary cusp and the right coronary cusp can be visualized, and we sweep the plane through, and we can image the left coronary cusp and the right coronary cusp, so that we know exactly which cusp is faulty. And we'll also take this opportunity to measure the annulus, and on echo, our standard view is an inner edge to inner edge measurement in early systole. So this is on transthoracic, beautiful pictures. We can also do TEEs to have a better visualization and use these same techniques. So you see on the left side, the 2D image, right away you can see there's a cusp that's prolapsed, the annulus is dilated, and then when we use the short axis view here, I can put the cursor exactly on the right coronary cusp and appreciate how much prolapsing this one is. And then 2D is quite useful, then we put color on it. And again, I can put the cursor exactly where the color jet is, and you can really appreciate how wide this jet is. Most of the jets of aortic regurgitation are eccentric, so we can miss it if we don't sweep through it. So this, using biplanar view, really allows us to do that. Then, we should report also different measurements that could be useful for you to know if the valve is repairable. So I'm talking about the coaptation height or the effective height. So we need to do it more as a standard of care for aortic valve. We do it for mitral. We measure all these measurements for the mitral, but I think more and more we're going to talk about it to have it integrated as standard of care for reporting our reports. So next up, we'll evaluate the degree of severity of aortic regurgitation. So one of the main criticism we get in the echo lab is that we undercall the severity. And I guess there's two reasons for that. The first one is that a lot of echo readers still rely on color. So eccentric jet will have a small, if you don't sweep through it, you may miss it. You're not cutting the plane exactly where the valve is. You'll undercall just by color Doppler. And also, our criteria, our echo criteria to define severe aortic regurgitation are very specific. They're not very sensitive, they're very specific. So for example, here you have severe aortic regurgitation, you have 7 criteria that you have to meet. You need to meet 4 of them, 4 out of 7, to call it severe. And individually, all these parameters are also very specific. So it's just too specific, in my opinion, and that's probably why we undercall it. Also, we can use a semi-quantitative assessment, such as pressure half time and other measurements that we'll go through, and we'll also use quantitative assessments, such as EROA, a regurgitant volume, and regurgitant fraction. More on this later. So on color, here are the parameters we look at: the jet width, the jet area, and the vena contracta. The vena contracta being very reproducible as a measurement. But again, if you don't put your cursor exactly where the jet is, you will miss the biggest area. So you really need to use that biplanar technique to pinpoint exactly where it is. According to the guidelines, here are the values, the cutoff values to define severe. Then using pulse and continuous Doppler views, we can also assess the jet density and deceleration time. So the more dense and the more hollow systolic, and the slope of the deceleration rate is very steep. That's in favor of severe, as opposed to a very non-dense and a slope that's not that slopey. And then we have here a hallmark of aortic regurgitation is the hollow systolic flow reversal in the aorta, whether it's abdominal or thoracic. So this is a very specific sign again, and not a lot of other diseases will give us this reversal, which makes it quite useful, especially when we don't see the jet very well. So I'm gonna make it bigger. So this is a pulse Doppler in the abdominal aorta. So the pointy up here, the positive is the systolic flow, and the diastolic flow is here, down here, where it's narrowed. So an area of that regurgitant volume more than 14 centimeters is a definition for severe, or in favor of severe. So those, then moving along, we can also quantify the degree of aortic regurgitation. So on echo, we use PISA. If we're able to get a nice shell here, then that's nice. We can see it and measure it. But again, we have to pinpoint exactly where that regurgitant jet is. So using a formula, we can calculate this. And this can be also easily done. Most vendors, echo machines, have these formulas integrated, so it's automated. Or more, which is more precise, probably is the volumetric method. So this is the same method that MRI uses. So basically what we do is that we measure, or we calculate by the continuity equation the amount of inflow through the mitral valve, and then we also calculate by continuity again the LVOT stroke volume that goes out, and we subtract both, and that gives us the regurgitant volume. So this is quite accurate and easy to obtain technically. We just need to measure the annulus of the mitral valve and the LVOT diameter, and using, again, automated or calculated formulas, we can easily obtain it as well. So these are the cutoff values according to our guidelines, and from the start, these values are for sure not correct. So actually, they're the same values that we get with the mitral valve. And as we know, the remodeling of the left ventricle is different with mitral and aortic regurgitation. The way the ventricle remodels is different. So it doesn't make much sense that these cutoff values would be exactly the same. We know the LV muscle increases in a different way, and we can, it's a bit out of scope for this talk, but these for sure will be revisited. And we're actually working on it right now to get new cutoff values on echo. And then finally, we'll also report different findings that are associated with severe aortic regurgitation, so LV dilatation, strain, presence of fibrosis on MRI. So a few words on strain measurement. So again, all the modern machines, echo machines, have strain measurements integrated in their packages. So whether it's Siemens, Philips, GE, are all automated. So they use like millions of echo to auto-detect the borders of the LV and give us very reliable numbers. So I would say nowadays, these numbers are accurate, and they do give us a number that's reproducible as well. So there's no reason why we're not doing it in echo labs, especially in the US. The machines have also the software. We get reimbursement now in the echo labs for giving this measurement. So really, this was becoming mainstream, I would say. And then finally, we'll also measure the aortic size using perpendicular view from leading edge to leading edge to get precise measurement of that. So I want to spend a few minutes also talking about the LV dimensions on echo. So again, I think there's a bit of a confusion regarding how accurate it is and how not. For sure, CMR is a technique that's the gold standard, and it's the gold standard because their measurements are automated, so the detection border has been automated, and it's been done before we have been able to do it on echo, so we have more long-term follow-up or long-term experience on CMR. But I will say nowadays, again, the echo machines are quite advanced. We get good definitional borders, so we can easily calculate 3D volumes, either with 3D measurements from 3 different views, from a 4-chamber, 3-chamber, and 2-chamber, or we can use ultrasound enhancing agents such as Definity contrast to obtain really accurate measurements of the LV. So again, LV volumes using 3D is accurate. We have different cutoffs compared to CMR, but these are accurate and reproducible. I can't advance it. Okay. So as the previous speaker said, we should not rely on 2D diameter of the LV, but rely on volumes. And again, we can obtain these volumes with echo. So here's an example of a patient. You see his end diastolic diameter is 64. His end systolic diameter is 6 millimeters, and here are the associated volumes. So if we would base only on those 2D diameter, based on our guidelines again, this patient, it's a man, he's I think over 6 feet, he would be categorized as a mildly dilated ventricle based on these 2D measurements. Based on these volumes, it would be categorized as being a severely dilated ventricle. But the same patient 3 years later had another echo, and those 2D dimensions did increase in size a little bit, but note that the LV in systolic diameter went from 46 to 47, which in fact should not be a big difference. However, when we get those volumes on echo, you see how much it increased. They increased by 30% on the volumes. So if we would have just relied ourselves on the 2D dimension, we would have reported this echo as being, there's no significant difference in the LV size. And if this patient happens to have severe aortic regurgitation, we would say, oh, the LV is same in size, but in fact, it is not true. It increased by 30%, which is quite significant. So just to caution, we should not be using 2D diameters. So speaking about new cutoffs, we alluded to that earlier. So this is not an echo study, but a CMR study looking at new cutoff values regarding the regurgitant fraction, regurgitant volumes, and the LV volume index values, and their impact on clinical outcomes after AVR, and these are the numbers that has come out. So we're working on getting those for echo, as most patients with aortic regurgitation or planning to have will for sure have an echo. It's technically harder to follow a patient with MRI in such a, serial MRIs could be quite difficult to obtain. So we're working on it, and I'm sure we'll have it in the next few years. So caution again about eccentric AR jets, not rely solely on color, but seeing as a whole and be aware of the caveats of each method, especially when they're eccentric. So in summary, echo is very accurate to define the mechanism of the aortic regurgitation and the associated findings. We'll provide you different criteria, findings that will help you guide the timing and the eligibility for surgery. We'll use different parameters to assess the aortic regurgitation. I believe that quantitative assessments with regurgitant volumes, fraction is the way to go here. It's easier to measure in time. And again, with all our echo machines with included software, we can do that accurately. And we'll pay extra attention for aortic regurgitation patients on the LV dimension, volumes, and function when we read your echoes. So I'll stop here. Thank you very much.
Thank you very much. That was great. Lots of questions, I'm sure, if we have time for questions. So our next speaker is Emmanuel Lansek, Surgical Principles of BAV Repair. Geraldine, you can come up here. You can bring your coffee.
Oop.
You can
Well,
set the new,
thank
set the new
you.
timer.
Thank you again for the opportunity to present on the surgical principle of bicuspid aortic valve repair. I will do that in continuity of my talk from this morning, and I do have a disclosure with corneo. So, as discussed this morning, the principle of bicuspid aortic valve repair is to treat the diameter, so address the aortic annulus that is dilated on bicuspid valve, address the STJ with either an STJ ring or a graft, and preserve the root dynamics either by doing root preserving surgery or valve sparing root replacement with neosinuses of Valsalva, trying to preserve the interleaflet triangles and line up the free edges of the cusp and restore the cusp effective height by placing the two commissures at 180 degrees. So there is a standardized approach of aortic valve repair, and this is what I'm going to present in the coming minutes on addressing the three phenotypes. Root phenotypes, which represent roughly 55% of the cases where I do perform remodeling with annuloplasty, and a supracoronary aorta, which is roughly 15%, with an open annuloplasty if the annulus is dilated, and isolated aortic valve repair, which could be treated with a double annuloplasty and represent 1/3 of the cases. So the technique for root pathology includes a sizing of the annulus according to the size of the direct intubation of the aortic annulus with EGA dilator. And if the annulus is around 29 millimeter, for example, I would use a 27 ring and a 28 graft in order to remodel the aortic root. The ring has been designed to be expansible in order to mimic natural dynamics of the aortic annulus. This is a typical example of root phenotypes where with an eccentric jet towards the mitral, angles by echo most of the time underestimate and visually they look more symmetrical. It is very important to assess the effective height of the non-fused cusp in order to have an idea whether you will have to resuspend it or not. Dissection starts at the level of the non-coronary sinus in order to reach the subvalvular plane. This is easy to do at the non-coronary sinus. This is also easy to do at the left coronary sinus. You need to cut this aortopulmonary angle and then cut all the fat below the left main in order to reach the roof of the left atrium and the membranous and the muscular septum. At the level of the right coronary sinus, you need to come closer to the aorta. At the level of the right non, you're far away in the muscle, but then when you come at the level of the nadir of the right, you need to come very close to the aorta in order to avoid making a hole in the infundibulum. At the level of the membranous septum, I recommend to go with scissors because this is very thin. You assess the geometric height at the level of the non-coronary, non-fused cusp, and you want to have more than 20 millimeter in order to identify the retraction. Then you put stitches in the subvalvular plane and avoiding the right non-commissure where you place the stitch externally in order to reduce the risk of block and lesion of the membranous septum. Then you line up the free edges of the cusp. You want to have equal lengths to the lengths of the non-fused cusp. It is very important. I mean, it's rather simple. You just pull on the two commissures, and in case of a redundant tissue or a little thicken, you can shave a little bit that free edge and line up the free edges on the referent cusp, which will be the non-fused cusp. Then you cut the graft into two symmetrical tongues. You can use either the Valsalva graft or the cardio roots. I would recommend to use Valsalva type graft because they're easy to use, and because the height of the commissure is the height of the diameter of the tube is the height of the commissure, and this fits nicely. I cut the graft symmetrically in two symmetrical sinus, so the valve will be forced to be at 180 degree, and this will nicely reconstruct the valve. Then you assess the effective height with the Schaefer's caliper, and you want to have 9 millimeter. If it barely touched the valve, the free edge of the valve, you just leave it. What you want to preserve is as much as possible the length of the non-fused cusp, which will be the opening long term of the valve. And then at the end of the procedure, you will tie the ring down in order to reduce the annulus. This is very important for bicuspid valve. They have dilated annuli, and this will increase the surface of coaptation and protect the repair. And of course, you do the echo assessment after, and you see the symmetrical design of the opening. Now let's move to the ascending aorta phenotype. If you have an ascending aorta more than 45 millimeter with a preserved root, which is not in a criteria to be replaced, and particularly I recommend to do CT scans where you can do a volume rendering. You see that the coronary ostia are lower than the sinotubular junction with a big non-coronary sinus. You can do an ME remodeling, particularly if the coronary ostia are below the sinotubular junction. So this is a typical example of an eccentric jet towards the mitral with a typical bicuspid valve, right-left fusion. So here you will dissect the roots similarly as for valve-sparing root replacements, but you will not detach the coronary. So you cut this out pulmonary ligament. You will open the roof of the tail sinus, so to free the PA from the aorta, and you see that you see now the left main, and you have a clear vision on the whole root. And this is very important to do that maneuver, and then you can go below the left main with a right angle. You can remove the non-coronary sinus. This will open the roots, like if you do a valve-sparing root replacement, except that you haven't detached the coronaries. You place your stitches below the annulus, one below the nadir of each cusp, one below each commissure, except the commissure between the right and the non, where you will place the stitch externally in order to reduce the risk of block and lesions of the bundle of ease. And then you line up the free edges on the non-fused cusp. This is always the same thing. What is very important for bicuspid valve is really to try to preserve as much as possible the free edge length of the non-fused cusp, because this will be the opening long term. I repeat it extensively, but I think it's key, because if you reduce too much that free edge length, you will have to reduce also the length of the fused cusp, and this will limit your opening. If the angle is asymmetric, which is almost constantly the case, you can plicate the sinus in order to reduce the intercommissural distance on the fused cusp. And this can be done with 2 stitches, pledgeted stitches. This is the equivalent of the Cabral stitches. This has been documented by Johann Schaefer's team from Hamburg, where they showed that plicating the sinus improved the valve stability towards a more symmetrical design of the valve, and that's easy to do. And this will, in combination with the ME remodeling, improve the symmetrical design of the valve. Then you cut the graft into two symmetrical tongue, again, like if you would do a full remodeling, but you remove one of the sinus, and this will lead you to a nice symmetrical reconstruction in combination with the plication of the sinus. So you have a good reconstruction of the root without having reimplanted the coronaries. Of course, if coronary ostia are higher than the sinotubular junctions, or if the aortic wall is very fragile, or in case of doubt, you can go for full root, but otherwise this works very well. And in combination with the sinus plications, this allows the symmetrical positioning of the two commissures, as you can see on this inner view. And you assess the effective height. You already know that this will be good. Placing the commissure at 180 degrees helps as well to lift up the effective height of the valve. And we have a good 9 millimeter here, so we don't touch it. And we will do an open ring annuloplasty. We don't have the open ring yet, although Dacron band do not ensure stable annuloplasty as an expansible CE-approved device. This is safe to use for isolated AI, and we will go around the ring with the stitches are placed in between the two stitches and is tight in the non-coronary sinus. And all the other stitches are placed around the ring in order to accommodate the symmetry of positioning of the cusp. And here is the root reconstruction with the nice neosinuses of Valsalva and a good effective height, a good coaptation height, and probably a mean gradient that has been measured, and the angle. When we do isolated AI, we'll do similar root repair, but rather than replacing the full root, we keep both sinus and annuloplasty will be done at the sinotubular junction level and annuloplasty level. This is a typical example of a bicuspid, again, repair with an eccentric jet towards the mitral. You see the prolapse of that fused cusp and the well-preserved normal shape, normal phenotype of the aorta, where all diameter are below 40 to 45 millimeter. We'll assess the geometric height. Here we have 25 millimeter on the fused cusp, which is very large, very redundant, 30 millimeter on the fused cusp, a very large annulus of 31 millimeter. Dissection is similar to root, except that you don't detach the coronary, so you go below the left main, and then you go below the right in order to free that space, and then you put your stitches similarly as for roots, one below the nadir of each cusp, one below each commissure, and avoid the bundle of ease at the level of the right non-commissure. And then you line up the free edges. So since you haven't detached removed the sinuses, you cannot stretch the both commissure at 180 degrees. So you have to go hemicusp by hemicusp and line up your free edges. So you check your assistant is pulling on the commissure, you're pulling on the nodiovarentius, and you keep, you want to have equal lengths. Then you can plicate the sinus in order to improve the symmetry of the valve, as we did for the hemi remodeling with the plication of the sinus. So again, a couple of stitches. This will help to bring the commissure towards a 180 degree configuration, and then you will do, instead of replacing the aorta, you will do an STJ ring. So this is placed with stitches that are placed at commercial level and at the level of that plication of the raphe. You put basically a 5 stitch. The commercial stitch are placed through the ring, the other ones are placed around the ring, and you tie it in the STJ level. So this is the equivalent of a tube without replacing the aorta. So you see that the commissure are becoming more symmetric. And then you assess the effective height again, and you want to try to preserve as much as possible that free edge length of the non-fused cusp, which will be your opening long term. Barely 9 millimeter is fine. And then you address the annulus dilation at subvalvular level with an open ring that is tight in the non-coronary sinus level, and you see that double annuloplasty repair, which will restore the ratio between the sinotubular junction and the annulus, which has been identified as a protector factor for long-term durability, increase the surface of coaptation, and protect the repair. And of course, you do your echo assessment at the end of the procedure, and you see a more symmetrical design of the valve and good results long term. So we have done on the latest analysis 1,700 multicentric aortic valve repair patients with external ring with a decent operative mortality. 12-year survival was similar to general populations, irrespective of the age. We showed that there was a benefit in terms of valve-related death and a major adverse valve-related compared to mechanical Bentel, and there was no difference in valve-sparing route versus a double ring annuloplasty with an 80% repairability rate for bicuspid and tricuspid valve. When we look at the bicuspid, specifically bicuspid population from my center, we're having coming up data on a multicentric setting as well. We showed that there is a risk factor was to only use single annuloplasty at subvalvular level compared to any technique that will stabilize and restore the ratio between the sinotubular junction and the annulus. 22% reoperation for single annuloplasty compared to less than 3% for stabilizing the STJ and the annulus. And symmetrical design reduced transvalvular gradients. Commissural angle was not a risk factor for reoperations as soon as you set up the commissure symmetrically. So to conclude, bicuspid aortic valve repair can be standardized in a symmetrical 180-degree configuration, trying to preserve the free edge length of that non-fused cusp, adapted to the phenotype, either with double annuloplasty and sinus plication or remodeling with sinus plication or remodeling with external annuloplasty. Thank you very much for your attention.
Thank you. Thank you, Emmanuel. Come to join us on the podium. It's my pleasure to invite the next speaker, Vinod Turani, who is going to tell us where do we stand with TAVI in patient with aortic regurgitation. Thank you, Vinod.
Great, thank
Maybe
you.
this talk is like 2 minutes, huh? No.
Well, this would be interesting. We're going to go from maximal, I'm trying to find, here it is. Maximal to minimal. Oop, it's the wrong one. Okay, great. Thank you. So I learned a lot from the previous speakers, and again, this is all open surgery. My talk today is more on the transcatheter and where do we lie with this. These are my disclosures. I think that there's a lot of rationale for TAVR in those patients that are pure AR. By the way, the slides that you just saw from Manuel, a very eloquent lecture on the bicuspid portion. None of these catheter valves are applicable to bicuspid, so it's all tri-leaflet. We all know that aortic regurgitation is bad. We don't know how much is there. What we're finding out is about 16% of patients have aortic regurgitation that have any valvular heart disease. At the end of the day, it looks like somewhere for severe, in some studies, it's been about 5% of patients who are just across the board have valve disease. If you look on the aortic guidelines, you see nowhere where transcatheter is within anything of aortic regurgitation. So I think by the ASC guidelines, there's really nothing there for TAVR. And if you look at the ACC-AHA guidelines, you'll see that there's, again, no aspect of where TAVR is applicable for aortic regurgitation. We will find out, you heard earlier, that if you have asymptomatic patients, if they're fallish for a couple of years, you will see severe, within 2.5 years, you see about 50% of patients become severe. So this is a process that we're still trying to figure out. You've heard some very good talks on repair and replacement, and I'll leave you kind of for those lectures that you've heard already. Where is surgery for AR for these patients? And if you look at it, and I'm going to go just a little bit quick through some of these, but what we're seeing is that if patients have medical therapy, they don't do very well. And so you can see the top line, survival with surgery, and the bottom is without surgery. And what I'll do is I'll just go forward a little slides, we save on some time. There are some aspects of current management of non-surgical management across the board, and these patients also do very poorly. And so if you look at the medical management for aortic regurgitation, look at the mortality. It's somewhere between 25 to 50% mortality at 1 year. So a lot of issues with that. So when we start to look at what happens with a heart team in evaluation for these, becomes really important. I think what I'll do is just go, my topic has changed a little bit. I think we're going to go exactly just to the TAVR portion to save some time. So there have been some TAVR procedures in AR, and you can see that there's been not great usage of current devices, the SAPIEN, the Coral Valve, and the Navitor for these patients, partly because of these major challenges, such that you see a device success rate of only 84%. That means that 16% had a failure from a device, and 10% required a second valve, and you see a very high 11% 30-day mortality. Remember, these are high-risk patients, not the patients that Emmanuel was talking about or Mark were talking about, which are low-risk patients. These are more high-risk patients. And what you see is that in another separate trial, you can see success rate from the Pantheon registry. You can see an 83.6% success rate, 12%, 1 in 10 patients had a embolization or migration. It's a big problem. Hence now there are really two valves that I'll talk about that have been utilized. One is the Trilogy system, and this is one that I'm the national PI for the U.S. global trial, in addition to some cardiologists. And here you can see that the valve functions this way, where it goes and grabs onto the leaflets. And if you look at this cartoon, you see that you're able to place the locators into the sinus. You release it so that now the locators have grabbed the leaflets, and then as you open the valve, it works exceedingly well, such that this procedure for me in my hands right now is about 30 minutes. What we've now published this in the Lancet, Torsten Vall and I are the national PIs for this, and you can see that this was recently published in high-risk patients, and I presented this last year. We looked at 180 patients with a 30-day primary endpoint and a 1-year endpoint. We looked at the safety and the efficacy. We found that these patients are about 76%, and their STS score is 4%, but all of these patients were considered high risk and were presented on a call to make sure that they were. 34% of them had frailty, had very high frailty levels. We saw 0 intraprocedural death and very good, no annual rupture, no perforation, no coronary obstruction. At the end of the day, instead of an 83% success, you can see the technical success now is 95%. This is a first-generation valve. At 30 days, there's a 2% mortality, and there is a disabling stroke rate of 1% for these patients. I think the major disadvantage for this is a new pacemaker implantation rate, which is about 24%. So when we looked at the safety endpoint at 30 days, the goal was 40.5, our rate was 26%, which gave it it met the criteria for non-inferiority. And when we looked at 1 year, we saw that the thought process in these patients was 25%, the actual rate was 7.8%. This also met non-inferiority criteria for the primary efficacy endpoint. Over time, the pacemaker has decreased. If we looked at the 180 patients broken in 3 pieces, you can see that the original pacemaker rate was 30%, and then it's now come down to 14%. The valve hemodynamics are unbelievable. You can see that single level gradients. The green bar, you can see about a mean gradient of somewhere between around 4 millimeters of mercury, which is outstanding. And you can see that the paravalvular for moderate severe, there's really zero moderate severe leak. There's about 92% have what we would classify as none to trace. So really unbelievable recovery for this. And you can see that the LV remodeling is heading in the right direction. Remember, this is for the original 180 patients. Just 2 weeks ago, we were able to present our series on 500 patients. Raj Makkar, myself, and Torsten Voll were the lead authors for this, and you can see that the 3 largest sites in the country are Cedars in California, Columbia, and Piedmont in Atlanta. And now you can see that the STS score average age is still 76. You can see the STS score is 4%, so high-risk patients. These are all still, every case has been presented in a case review committee, which assures that they're high-risk patients. You can see that across the board, the intraprocedural death is still 0. There has been some patients that have had valve embolizations for these. And when you look at 30 days for all 500 patients, it is still well within the non-inferiority margin. If you look at the following all-cause mortality, remember I showed you a 2.2% in the first series, it's now down to 0.9%. So in the ensuing 320 patients, we have cut the mortality by more than 50%. And you can see that the pacemaker rate, however, is still 23%. And I wanted to highlight those 2 things. That's still something to think about. When you look at the primary efficacy at 1 year that Dr. Makkar presented just 2 weeks ago in Chicago, you can see that we're well within the margins. At the end of the day, we've seen a doubling of mortality. In year 1, we saw 8.1%. At year 2, we're seeing about a 15%. Most of that is non-cardiovascular mortality. About half of it is cardiac mortality. And you look at the hemodynamics, the valve is working exceedingly well. You can see that the mean gradient is still 4 at 2 years of follow-up. There is almost no regurgitation. There's only 4% with mild. Everything else is none to trace. And you continue to see great LV remodeling out to 2 years. You can see in the first LV EDV index was 82, and it ends up at 65 by the time you're 2 years out. Overall, patients feel good, and they've gone from 58% KCCQ to a 79% at the end of 2 years. You can see the majority of the cases are 28% of the cases are in the larger valve, and this is a predictor for pacemakers. We're seeing that the larger valve that you put in, the higher chance for pacemaker, but also a right bundle branch preoperatively also is a predictor for a new pacemaker. There are 2 new trials coming up for the UniValve. One is the VAD registry, which we're just starting in the United States. And one, now having seen the high-risk patient population, the ARTIST trial. Myself, Raj Makkar, and Torsten Voll will be the national global PIs for this. And Stefan Baldus and Hendrik Trede from the European side will be the OUS. And this will be this will be the very first randomized surgery versus catheter valve for aortic regurgitation. This is not what Emmanuel or Mark have shown you. These are patients with no large aneurysms. These are pure AR patients. And they do not, they will not be patients who get a David procedure or other type of procedures. It's purely AR versus AR. I wanted to mention the J-valve, which has the second largest experience in the country. This is now an Edwards Life Sciences company. This can treat a little bit larger. If you look at the very top line, the UniValve treated up to 90 millimeters. This treats up to 104 millimeters. And this is approved in China for AS and AR, and that is currently being investigated in the United States. The best data we have so far was presented last year and recently published. You can see there's 15 patients that had 0 mortality interprocedurally, and so overall the data looks good. Again, only 30-day outcomes here, and they did have 1 patient that led to a 6% mortality. Again, it's only 1 patient. So tomorrow I have a talk that I go a little bit more into the J-valve data for this. So I say that, overall the conclusions for aortic regurgitation where TAVR fits in. First of all, there are 3 major problems with the management of AR. It's completely underdiagnosed, it's completely under referral, and there's complete undertreatment of this. There are newer AI surveillance systems that may allow this to come up. We didn't get time to talk about that. And we're addressing the gap in the treatment with some dedicated AR procedures. It first started with high-risk patients, and now we've seen that the high-risk patients, the JenaValve does well, except for the pacemaker rate. But we're now seeing for the first time randomized trials coming in of over almost 1,000 patients comparing the two techniques in lower and intermediate risk patients, and there are newer dedicated systems that are coming forward. Thank you very much.
So our final speaker will be Jonathan Butcher, Professor Butcher, using computational models to understand valvular biomechanics and improve valve design. Professor?
Thank you very much, and I will try my best to keep with time so we have some discussion. So I have a big task to try to communicate the possibilities as well as the realities of the opportunity for computational simulation to support not only decisions that might be made in the OR, but also on the bench to help accelerate repair strategies, design strategies, and also to understand biology. So as we all appreciate, the aortic valve is a tremendously complex multi-scale structure. So in addition to the differences between the root and the leaflet, we also have multiple layers of tissues within each of those different domains. Furthermore, this root is deforming differently almost at every location of this conduit, and it's being subjected to very complicated tissue mechanics as well as fluid environments. And each of these are driving underlying biological processes to continuously adapt this tissue for long-term function. Or in the case of disease, these forces may even propagate the disease program. So the operation of the valve, as we've seen this morning, has been a subject for 500 years of inquiry, although in fits and starts. But one interesting feature that we should keep in mind is the value of the seeing of the dynamism of the valve. So this has been appreciated by many surgeons, being able to see how this operates, the integration of tissue dynamics and fluid dynamics together has been something that we now continue to use in clinical decision making, just even looking at the flow fields to make decisions. But unfortunately, not every surgeon can see every valve, and as we have thousands of surgeons and as we learned 180,000 patients a year, how do we actually integrate all of that data to make better decisions? And this is the opportunity and the reality for computational modeling. So not only can we use these approaches to quantify what we see in a qualitative way, but start to use that information to then understand local phenomena that were more difficult to see. And using those numbers, we can refine performance risk and relationships between mechanical and biological parameters to be able to then use the simulation to assist in diagnosing not only the etiology of how a valve became diseased, but also to support clinical decision-making, meaning how best to intervene, when to intervene, and what to intervene with. As we've learned this morning, this is a very significant decision for the benefit of the patient. And then furthermore, to predict prognosis of a patient, how to intervene further, thinking about potential failure modes, but then also to support design. So if we want to intervene in addition on the surgical side for the engineering side, what should we make? When should we use it? How should it work? So computational modeling in the heart valve space, in addition to other biological spaces, we have tremendous advantages in being able to utilize simulation to basically determine unmeasurable phenomena in other contexts. When we have echo that we've just learned can generate a lot of parameters, getting that local, spatial, and temporal information is something that's very difficult. Simulation can provide a lot of possibilities that are not experimentally obtainable. Moreover, you can use simulation to reduce a very complicated experimental space to refine for a specific subset of experiments that are more likely to yield significant information returns. And so when you combine those two, you can have an accelerated scientific discovery. However, just like we've heard in many kinds of computational environments, garbage in, garbage out. So the quality of the data sets that we have to be able to support developing models to explain these phenomena are very important. So if we don't have any information, we start making things up to fill in those gaps. We get a simulation that might say something, but is actually not very helpful. So we have to continue to work with the data sets and then the ownership of those data sets, et cetera. Fortunately, as we've learned today, 180,000 patients a year, each one of them may be getting multiple clinical data sets. There's a lot of data that could be utilized towards improving these computational approaches. So I'm not going to do any math. This is the only kind of math that I'm going to show. Basically, it's not even math, it's just logic. But I want to highlight the different information streams that are important to thinking about the simulations that we may be talking about for the future. So it's not just about mechanics and fluid, but we have geometry, we have underlying material structure, we have biology, meaning the living components that may determine the remodeling outcomes, right? And then we also have time evolution, so the things that happen as patients age, the things that happen as a disease progresses. All of those are very important inputs that need to be synergized in a computational framework to best assist all of the kinds of decisions that we've been talking about this morning. And so I'll give several examples that have been utilized in the literature to help improve valve design, surgical implantation, et cetera. So this is an initial study looking at even the very tip of a mechanical valve prosthesis. Changing local angles, local dimensions can have a profound effect on whether these valves deliver a significant shear stresses and hemolysis. So you can use these simulations to not only predict risk, but also to refine the geometry of the device to improve that performance. We can do the same thing to improve TAVR design. So thinking about how to design the leaflet shapes, leaflet thickness, leaflet sizes to minimize the chances of platelet dispersal and hemolysis, as well as paravalvular leak. And this involves not only the leaflets, but the stent, where to put the stent, how to rotate. As we heard before, a virtual environment could be a great asset for surgeons to optimize these positionings. Similarly, when you deploy the stent, it's actually interacting with the solid tissue of the valve itself. And so you may be imparting forces onto that root that will then have a significant consequence in the downstream remodeling and ultimate durability of the entire system. So we have multiple features. So connected to that, there's also, as we've heard, about the importance of the Ross procedure for younger patients. We are well aware that for a subset of patients, you do a Ross procedure, particularly in growing children, and instead of growing well, this conduit would tend to dilate over time, and that is a significant clinical problem. And so one strategy would be to support the root of this wall from dilating too much with, say, a support cuff. Well, so this particular example, you could design a support cuff to be degradable or non-biodegradable, and you can find that you actually have to balance stress shielding as a mechanical stimulus to the cells to then actually negatively remodel the wall to make it even weaker. Or you could use a biodegradable scaffold that temporarily supports this wall as the patient is growing, and then the scaffold degrades, and you have essentially a convergence where the material erodes in concert with the natural growth, and you end up reducing the risk of this dilation. Again, computational simulation is much preferable than trying many different grafts in many different animals. And so one of those limitations to utilizing simulation is it takes time, right? So if you want an answer in an OR, you need to have it basically then, as opposed to, wait 2 weeks and we'll tell you. So artificial intelligence and machine learning approaches are being developed to accelerate those simulation frameworks at the potential cost of not really knowing what's going on in the middle. And so this is actually closer to natural intelligence when we're looking at, echo streams and MRI and seeing these flow streams and inferring what's going on underneath. Computers can do that too. And again, the quality is based off of the data that you input to be able to understand the output. And so these combinations or approaches are now accelerating our ability to support decision making almost in the real-time nature of the OR. So another utilization of computation that is transforming engineered valve design is to incorporate living remodeling parameters of the cells themselves within the tissue matrix to be able to ascertain what structure to make living valves so that when they are remodeling, they don't induce negative things like leaflet contraction, as we've heard, as a significant problem. So this is one example, a very successful example of utilizing computational simulation to identify a geometry that will be least likely to end up regurgitating, and that was a significant recent clinical finding. So this same group is expanding that to look at parameterization across all sorts of different geometric parameters so that you could design a valve that provides the ideal mechanobiological signaling locally into this graft so that it is supporting not only the stable leaflet coaptation, but maybe supporting the growth and expansion of this valve. And then furthermore, you can develop what we call cost functions to be able to optimize specific parameters that a clinician may want or a patient exhibits, for example, age or gender or something, to be able to minimize the amount of error or maximize the performance chance of these particular valves. So then thinking even closer to the design of these valves, replicating tissue microstructure is a significant additional component that we're very interested in. So in our group, we've been using tissue printing technology to manufacture both anatomically complex and microstructurally complex tissues. And so thinking about these same questions about patient-specific geometry or designing for different sizes, you can use computation to actually optimize the deposition paths to be able to replicate each specific patient or to design a set of geometries that might work off the shelf. Moreover, you can implement simulation to figure out ideal material properties to put in each location. So to that example, you can make microfabricated environments to test the biological stimulation of a heterogeneous material environment, which exists naturally but has been difficult to put on the bench using these kinds of technologies where now cells can be exposed to gradients similar that they would experience in a vivo situation and in a complex tissue. You can combine those together to make a anatomically complex and then microstructurally heterogeneous material that's been using computational approaches to be optimized with only a subset, meaning an integer number of deposition nozzles, to best mimic that complexity on anatomy and microstructure. Furthermore, you can use these same tools to add tertiary level complexity. So instead of just making a leaflet like we might see in polymers, you now have corrugations in that leaflet, which naturally replicates the crimping pattern of these tissues, as you might see in the OR videos. So these different combinations enable not only precision, but different axes of freedom to be able to optimize and understand how these different components combine. And so this is where collaboration between the engineering and clinical community, I think, is really important, because at the so-called back end now, as we're trying to use models to understand the interaction of all of these different degrees of freedom in terms of biology and mechanics and anatomy, these can be done in individual labs. And those are really great things to support the extension of. However, as you move towards, say, developing an actual conduit to test, you have to lock down the design, right? So that you can run it in animal trials, et cetera. If we could develop virtual models, virtual animal models, virtual, in design environments, we can hopefully extend this collaborative and creative environment so that we don't have the restriction, so that the trials continue to be, 5 years back from what's going on in the bench. And so this is, again, where the clinical data that has been developed across the all of these surgical teams are very valuable to helping this manufacturing process that's going on in the bench. So I hope that this can be something that we continue to explore in this society, as well as in your individual research teams. So with that, I'd like to thank you, and I guess we'll move to discussion.
Well, we don't have, go ahead. We don't have not much time, maybe two or three questions. So the audience, if you have any questions, please come up to the microphone. Oh, Dr. Morale, go ahead.
Thanks. Thanks very much. Great session. My question's for Vino and the randomized trial for AI. So, we heard from Emmanuel that 80% of the pure AI valves were repairable. So my question is, how, I might have just missed it, but is there an age cutoff? How are the valves are bicuspid valves being included? And is the valve being assessed for repairability, or is that just kind of thrown out the window?
Microphone is on. It is now. Is it? Can you hear me, Mauro? Okay, good. So, very great questions. So, number one, a surgeon and a cardiologist have to present the patient a case review committee. It won't just be selected like that. You have to present it. The surgeon has to say this valve will not be repairable, that it will be replaced. In the United States, we can come to meetings and we talk about all these beautiful stuff that we do. Quite honestly, most pure AR patients in the United States are not being repaired. Okay, there's 1,100 sites in the United States, and the majority of surgeons are not repairing their aortic valves. And so for the most part, these are patients that will be replaced. These are trileaflet valves, not bileaflet valves for the most part, and the surgeon has to say that I will not repair this valve. So it'll be a true comparison of a replacement with a replacement.
And are the surgeons involved in the trial, surgeons who repair valves?
Absolutely, and so that group has to say, this is a patient, if they think they'll repair it, that patient will not be part of the trial. They'll repair it on their own without actually going through the trial. So I don't think that there's equipoise in a patient that can be repaired and a Yenna valve. I think there's no equipoise towards that. The surgeon has to say, in my center, in my hands, I will replace this patient, and that patient will go in.
Was it discussed when you designed the trial, was it discussed to randomize repair versus percutaneous valve replacement?
I think that's a whole different study, quite honestly. And I don't, because it's a replacement versus replacement, I think that's a tough randomization to do, quite honestly.
Yeah.
But I think that's his own trial, Emmanuel. I think that there should be a repair versus replacement trial in aortic regurgitation. That's never been done before.
So we only have one more question. I'd like to ask one of Dr. Ong. So volume is king, it looks like. Mark Peterson has told us that's the future of the guidelines for AI and indication. Is echo volume, has echo volume and CMR volume been validated together? I mean, which one's the gold standard? Are they the same when they're put up against each other? What does it look like?
Yeah, so the the dimensions will be different. So then what's considered normal on a 3D volume 1 echo will be different from what it is on a CMR. We haven't quite...
that's not good.
We haven't quite decided what is mildly dilated, moderately dilated, severely dilated. Those cutoff has not been quite established yet on echo. The reason for that, why it's different, is that there's less variability in the image acquisition for CMR than there is for echo. Although we're working hard, like the echo community is working hard to have to standardize and using artificial intelligence with auto detection of their borders will standardize that. We're still not there yet as we are with CMR. That's why it's different.
Well, that's a great answer. Nice and short. I loved it. Unfortunately, we don't have any more time, and I'm supposed to announce that in this room it will be the Artivion lunch, which is basically about Ross. And the next room is the Edwards Lunch right next door. And thank you very much for attending this session.